And I'll be presenting a case of neuropsychiatric manifestations of systemic lupus erythematosus. Background: systemic lupus erythematosus, or SLE, is chronic autoimmune disease characterized by autoantibody production and immune complex formation. Renal and central nervous system, or CNS, involvement accompanies severe disease and accounts for a large proportion of morbidity and mortality. We present a patient who presented with neuropsychiatric symptoms in the context of acute ischemic stroke and focal seizure as initial manifestation of SLE. Our patient was a 42-year-old African-American female without significant past medical history. She presented to our ED with generalized weakness, recurrent syncope, and forgetfulness for 3 weeks. On initial physical exam, she had proximal weakness of the left lower extremity with 3 out of 5 strength upon hip flexion. Of note, there was no evidence of any oral lesions or skin rash. Initial labs revealed anemia, leukopenia, and elevated inflammatory markers. Urinalysis was without proteinuria, and a CT scan of her head was unremarkable. However, an MRI of her brain revealed a small infarct in the medial left temporal lobe in the setting of subcortical white matter changes secondary to chronic small vessel disease. Her hypercoagulable panel was unremarkable, and she was initiated on goal-directed therapy and subsequently discharged. Unfortunately, she returned a month later following a witnessed focal seizure of her left upper extremity. Autoimmune workup at that time was remarkable for persistently elevated ESR of 111, C3 complement of 40, and C4 complement of 8.4. Her ANA was a 1 to 320 ratio with the low titers ranging from 140 to 160. She had a speckled pattern of distribution. Her anti-double-strand DNA was positive with a titer of 1 to 640, nor being less than 30, and other autoantibodies were negative. An MRI at that time, with contrast, revealed multiple scattered foci of restricted diffusion in bilateral posterior MCA territories with subcortical white matter changes that appeared consistent with cerebral vasculitis, as shown here in Figure 1. A diagnosis of probable SLE was made. She was started on levetiracetam 500 milligrams twice daily, hydroxychloroquine 200 milligrams twice daily, and prednisone 60 milligrams daily, and subsequently discharged. Discussion. At least 5 million people worldwide have SLE, and about 75% may develop neuropsychiatric manifestations, known as neuropsychiatric systemic lupus erythematosus, or Npsle. Neuropsychiatric manifestations of SLE are difficult to recognize and treat, as they remain one of the least understood complications of the disease. It may be an exceedingly prevalent and often overlooked manifestation of SLE, as it can present in absence of traditional serologic markers. The evolution of Npsle is thought to be secondary to many factors accumulating in the generation of autoantibodies, with immune complex deposition and a cascade of inflammatory cytokines leading to neuronal injury. It is crucial to recognize that neuropsychiatric manifestations of SLE often occur in the absence of other systemic manifestation, and at times it can be the initial presentation of SLE, especially because Npsle has been associated with worse prognosis than traditional SLE. That's why a multidisciplinary approach can afford early recognition when it may be more feasible to halt disease progression.